Good morning, everybody. My name is Catherine González Castro. I study nursing in the Universidad Católica de Santiago de Guayaquil, and I will talk about the secondary surgical cytoreduction for recurrent ovarian cancer. Definition: the ovarian cancer is a type of cancer that begins in the ovaries, often was undetected until it has spread within the pelvis and abdomen. At this late stage, ovarian cancer is more difficult to track. Here we have a video about this topic.
There are two large randomized control trials that demonstrate the role of surgical cytoreduction in recurrent ovary cancer. They were both presented at ASCO within the last few years, and neither are currently published. We're awaiting the final data, but unfortunately they have conflicting results. So the large European trial demonstrated that there are patients who have a good performance status, low volume of ascites, and those who had an initial primary cytoreduction that was optimal. Those patients may be good candidates for secondary surgery. In addition, in their trial, they demonstrated a progression-free survival benefit. So those patients did well. However, in the GOG portion or version of the trial, there was no advantage of progression-free or overall survival in the patients who had surgery and chemotherapy versus chemotherapy alone.
Application in nursery. The objective at surgery was the resection of tumor to no gross residue. During the assessment of the chemotherapy objective, surgical amenable, patient also underwent randomization to paclitaxel and carboplatin intravenously or to paclitaxel and bevacizumab every 3 weeks for 6 cycles. Pros and cons. The hazard ratio for the surgery versus no surgery was 1.29 weeks, corresponding to a median overall survival of 16.6 months and 16.7 months respectively. Here we have a video about this.
Hello and welcome to Onc Live Peer Exchange entitled Practical Implications for New Treatment Strategies in Advanced Ovarian Cancer. I'd like to focus on recurrent ovarian cancer. Although there's great hope for cure in newly diagnosed advanced ovarian cancer, and although we have new FDA approvals in the frontline setting with niraparib in all comers, as per April 29th approval of PRIMA, and as per the FDA approval of PALA-1 on May 8th with olaparib and bevacizumab in the HRD cohorts, it's difficult to say, but still true, that most of our patients develop recurrence. The first agent approved in recurrent ovarian cancer, of course, was bevacizumab. This was in November 14th, 2014, Aurelia. This was a very small step forward in platinum-resistant recurrent ovarian cancer in second or third line, with a hazard ratio of 0.38 and only a 3-month improvement in progression-free survival. But then in December of 2016, we got a platinum-sensitive option, which was a little better, which had 2 chemotherapy backbones, carboplatin gemcitabine a la Oceans, and carboplatin paclitaxel a la GOG 213. And Ocean showed a little bit better improvement in progression-free survival with a 4-month improvement, but Oceans GOG 213, a 5-month improvement in survival. So that was good. It's definitely not enough. I think most of us sort of prefer bevacizumab in the frontline setting. Leslie, I'm going to ask you, what percentage of patients do you think with ovarian cancer get bevacizumab at some point?
Hopefully most. I mean, with it being frontline, platinum sensitive, platinum resistant, really, you know, and being an active drug, I would hope that most of them, if not all of them, receive Bev at some point.
Yeah. So in the platinum resistant setting, Shannon, sort of, you know, all else being equal, what's your preferred chemotherapy backbone of those 3 Aurelia options?
I tend to lean towards the weekly paclitaxel. I think, you know, we saw in the lab that there's something about the way those 2 drugs interact that we get a even more bonus anti-angiogenic activity. And I think the patients tolerate it really well too.
Yeah. So the 2 approvals, Matt, in our country, are, as you know, are CarboGem, carbopaclitaxel in the sensitive space, but there's a lot of discussion about carbo-PLD as a 3rd option. What's sort of your go-to regimen in the platinum sensitive space if bevacizumab is a part of that?
Yeah, so, you know, certainly looking at patient factors to help drive that, you know, the advantage of the PLD regimens, clearly the Q4 week dosing schedule. So sometimes that's driving it. But really looking at the quality of the level of the data from 213, you have an OS benefit with the addition of giving Taxol again, so carbotaxol plus bevacizumab. So really, you know, I think that's my go-to regimen when I actually have that additional bar beyond PFS. You have that such strong, you know, again, right at the statistical cutoff, but it is positive when we look at OS.
You know, I think Shannon said it very nicely that, you know, there really is some special interaction with paclitaxel and bevacizumab. You know, whether it's cervical cancer, platinum resistant or platinum sensitive ovarian cancer. So,
and you really hate, you know, you hate to make neuropathy worse, but there's a lot of tricks that we have to try to minimize that, alternate taxanes and things. So I think we can get patients through this. They're just not real excited about losing their hair again. And so it can be a little bit of a lengthy discussion.
ISUA applied in Ecuador. In Ecuador, cytoreductive surgery is important and a very fundamental part of ovarian cancer treatment. Multivariate analysis demonstrated that the optimal result of cytoreductive surgery was an independent prognostic predictor of survival in patients with stage 4 ovarian cancer. Conclusion: secondary surgical cytoreduction in patients with platinum-sensitive recurrent epithelial ovarian cancer selected according to this criteria appeared to be feasible with acceptable postoperative morbidity. We have a video for Dr. Fowler.
It's usually the first decision point that we have when a patient's referred to us with what appears to be advanced stage ovarian cancer. Age of the patient is a critical variable. There's different age. There's not an age limit. Some use age 65, some use up to age 75, but it's age combined with what their medical comorbidities are or aren't. In other words, their performance status, their anesthesia risk score, and then other findings that may give us hints of how aggressive we have to be at surgery. So we use a combination of that information. If the patient's in good health and we think there's a reasonable opportunity for optimal cytoreductive surgery, our approach is to take that patient to surgery, give them the benefit of the doubt of primary cytoreductive surgery. If they have risk factors that would predict higher incidence of side effects or even 30-day mortality, those are the patients that will start with neoadjuvant chemotherapy. with the goal of an interval cytoreductive surgery.